everyone to the first community learning track call, and all up to our June 16th training, January 16th training on performance management. This is for health innovation, healthcare workforce learning and relearning curriculum. As you might remember, every module will have a pre-work webinar, it'll person training session, and then 4 community learning track calls. You know that the intention of the community learning track calls are not series of webinars. It will include information out by different experts, but what we're hoping is that each that attend the community learning calls will participate actively and do the homework in between each call so that you can come together and share what you're doing and your best practices and barriers to create a community learning environment with the practices that are involved in this training program. So I want our community learning schedule. As you might remember, the curriculum is being provided by the University of Delaware and Health Teamworks. I'm Nicole Diener, the Director of Education and Training at Health Teamworks, and I'll be providing today's community learning track call. So mentioned with this module, there are 4 community learning track calls. Today, we're going to be talking about the importance of empanelment, and we're going to overview of risk stratification. And like mentioned, you will have an assignment, and that one will be around empanelment for today's call. On 10th, we'll come back together and we'll do some practice sharing on empanelment. That's where we really want to hear from you guys about best practices and barriers and sort of have you guys share together. And we'll be doing a deeper dive into risk stratification and into methods that have worked for practices very well. And at the end of that community learning track call, there will be a risk stratification homework assignment. 24th, we will again do practice sharing on how it's going among you with stratification, and we will talk about population management during that call. You will population management homework assignment. We'll come together for our final community learning track call for Module 1 to do, again, practice sharing on population management, and then conclude the community learning track with information out about utilizing data for performance improvement. And we will shift to Module 2 on population health management and IT enablement, and we'll discuss that at the very end of the webinar, the schedule for the next module. So to mention, we're going to do a deeper dive into empanelment and do a brief overview of risk stratification. Sources for this call are to define empanelment, articulate why empanelment is an important and crucial first step in transformation activities, stratification, and the relationship between risk stratification and population health management. So here, Health Teamworks really feels like things happen in a very stepwise manner. The first step at the very bottom of the pyramid being empanelment. I feel you can achieve the steps above empanelment without doing empanelment first. I attended the January 24th event and the event on the 16th, the in-person training. You'll heard me mention several times that empanelment is a crucial foundational step that comes before any other practice transformation activity. Empanelment naturally leads to a risk stratification ability where you can take your actual active panel and figure out who are your highest risk patients, your moderate risk patients, and your low risk patients in order to be able to assign appropriate resources. And naturally leads to an effective population management ability where you now know who your active patients are, who your panels are dividers if you have more than one provider, and opens the opportunity to try to figure out what population management activities should happen for what level of risk of your patients. And then the ability to do all of those things will lead to performance improvement and the ability to really focus your efforts on quality improvement and performance improvement. So what is it? It seems really easy on the outside. I think we all think we panel, and we probably know who our patients' primary care providers are. And the definition of empanelment is the act of assigning a patient to a primary care provider or a teamlet who, with support from a care team, assumes responsibility for coordination of comprehensive services for his or her panel of patients. Really, as you already know, between the patient and family and the care team is really at the heart of patient-centered care. So the empanelment are important, and I've already mentioned some of those, and others now. One is really the ability to provide sustained continuity of care to patients. So by assigning appropriate levels of panels to appropriate providers, it allows patients to see those providers in an ongoing way, and the providers that the patient really feels are their primary care physician. And we already know from the research, continuity of care leads to decreased hospital admissions, decreased ED visits, improved receipt of preventative services. So continuity is a crucial outcome of empanelment. Obviously, with continuity, there's improved satisfaction, there's relational continuity, there's informational continuity, there's personal self-responsibility and patient involvement. We know as patients and providers how important it is to have that patient hear a continuous message from a team that knows them and a provider that understands them and the care they need. Our care team satisfaction. So there's decreased frustration when a team feels like they're preparing for, treating, and following up on patients that they actually think are patients, versus seeing new patients all the time that are unknown to them and trying to provide care to them. As you mentioned, empanelment is the basis for population management. Panels of patients are crucial to panel assignment and panel balance and access and continuity. So, as we'll talk about next during risk stratification, lead logical assignments of responsibilities based on risk, and it's to fewer gaps in care. So, empanelment, and we'll go into these in a little more detail in a few minutes, but essentially step one is really assigning a panel manager who's going to be taking responsibilities for cleaning up and maintaining our panels of patients. So that's a crucial first step. That would be a quality improvement team. It doesn't necessarily have to be a single person, but someone or some function within the practice needs to have the panel manager role. Step here in a little bit is documenting. So deciding where in the EHR that you will document the PCP, where those panels can be pulled easily. So in agreed upon done process, we're documenting the primary care physician in the EHR. Something that already is really crucial in this, and again, we'll go into more detail in a few minutes, and that's defining what is an active patient to your practice. That's determined by your system. If you're owned by a system, you have policies where you have defined it, and it's worth confirming or to define how you as a practice will we have active patients. And again, we'll go into that in more detail in a few minutes. It's an essential step where if you haven't done this actively or you haven't done it for a long time, it's really going through that foundational step of looking at your panels either at the practice or the system level, and based on how and where you said you document it and how to find the active patient, doing an initial cleanup of the panel. That's an essential first step that doesn't have to include providers. This can be behind the scenes. If providers in practice have agreed to your active patient policy definition and where you'll document it, they need to be involved in that first cleanup process. But in 5, it is crucial that providers are engaged in defining that the patients listed on your panel are their patients. The stretch goal and the ideal state is if both persons and patients are involved in saying who their primary care physician is. So practice may define a provider as a patient's PCP, but the patient may see it very differently. So how do we engage him or her in that process? And we look at the Empanelment manager, how do they maintain that? What are our policies and procedures around how often management will occur, and how does that information get updated? About panel cleanup, there's a pretty simple 4-cut method. And I say here that we're going to be sending you the Health Teamworks Empanelment Reference Guide. It's a 2-page guide on how to do empanelment, and we'll be referring to that later in the presentation. And this 4-cut method is articulated in that, and you'll receive that via email after the webinar. So the cut method is that the first cut, so we're looking at your panels either at the system level or at the practice level. If a patient has only seen one provider in the past year, you assign that patient to that provider in the appropriate documentation place in EHR. If you have seen multiple providers through the last year and you can't use the first cut, you can go second cut, which a patient may have seen multiple providers, but they saw one majority of the in the past year. And send the patient to the provider that they saw the majority of the time over the last 12 months. Some patients have seen 2 or more providers equally in the past year. This was especially true in residency practices in which I worked, where residents rotate in and out of the practices, and there were teamlets that provided care to patients. This is one specific PCP. And so no majority provider can be determined. If that's the case, in the third cut, you assign the patient to the provider who performed the last physical exam. Cut is patients who've seen multiple providers and they had a physical exam. So you assign them to the last provider seen. So I hear that the 4-cut method seems to be, from our experience doing this over the last 5 years, as the most simple, straightforward method that providers and practices and care teams can agree to. It by no means is the only method, and based on how you decide to empanel, what your providers agree to, and who your panel manager is, you can determine the best method for your initial panel cleanup. For me, this seems to be the most simple and straightforward to go about it. So it's out there to define what a perfect panel size is. I have a moving target at this time based on your team-based care delivery model, how sophisticated you are with risk-adjusted panels, and things like that. So truly today and moving in the future, it's going to be a moving target what the perfect panel size is. Although that on a system level or a practice level, getting some agreement on panel targets is a very good idea. And so a great starting place for a conversation about what do we think the current panel for a specific type of provider should be. And we'll talk about that in a couple of minutes. There are provider considerations for empanelment. So when we're looking at our nurse practitioners, our physician's assistants, we really need to think about how they will or will not manage a panel. Decisions are based on state regulations, whether level provider is a new graduate or experienced, how your medical director or medical leadership or practice director are with assigning panels to mid-levels. And just keep in mind, if you're thinking about pursuing NCQA or other PCMH recognition, they only extend that recognition to mid-levels if they are assigned panels. That's a crucial consideration, not only when it comes to empanelment, but when you look at how to staff your provider teams and teamlets, you want to handle mid-level providers. And that's both in a cultural decision that's really based in your context and where you are. Questions that come up. So when I first started doing this in residency practices, and they'd gone through the assignment of a panel manager, they had pulled the panels of providers, They had found active patients and cleaned up their panels. Inevitably, the provider panels were all over the place. Some 800 patients, some had 4,000. And so it's all sorts of misbalance among the providers and their panels. And it becomes, how do we adjust panel size? And an over-paneled provider is a very good idea from the perspective of access and continuity. So once you've sort of determined the panel target for your specific type of provider, when a provider is significantly over that, you definitely want to close those panels until you figure out how you're going to manage that. All providers, potentially adding support staff. The hardest thing to do from my experience is removing patients from over-paneled providers and assigning to under-paneled providers, because they don't look nicely upon being reassigned to a provider when they feel strongly that one is their primary care physician. That's an option in the third and fourth cut when you go through the four-cut method, when one's seen multiple providers and one really the majority of the time. That can really consider looking at taking over panel providers and reassigning panels without too much impact on patient satisfaction. That is a patient engagement question. MGMA's cost survey data from 2013 that was based on 2012 data. You can see here the primary care median panel size. So all primary care, it's around 1,485. For single specialty, it's around 1,700. Multi-specialty, 1,400. Physician-owned, 1,400. And hospital-owned, close to 1,700. These are not what we're telling you your panel should be, but these are based on MA data points about what was happening in 2012. So, before we talk about this, so I experienced the residency practice, an individual practice that we went through this process, and we saw that some panels were very high, some were low, and a very big imbalance within teams and across and among providers. I've done empanelment and risk stratification at a system level. So I've mentioned this in the last two presentations I've done, but I think it's really worth highlighting here. So 23 practice multi-specialty group in Phoenix, owned by corporate health plan. And they were very sophisticated in their data and their population health management and their 5-star HEDIS and doing a lot of things well. They had a centralized population health management team, but they had never done empanelment and risk stratification. And so they were sort of going to this where they wanted to add team members to support their practices, like behavioral health, PharmD. They want to take another look at their population health management team that was centralized and off-site to the practices to see if we're allocating resources effectively. And when we went through the empanelment process for every practice and every provider in their system, we realized once they cleaned up the panels during the four-cut method, they defined the active patients and took out their inactive patients. What they realized was that they were actually 6 providers over capacity. When these 3 practices, they actually had 6 FTEs worth of providers that had been panels. Those didn't represent 6 people who had full panel availability, but they're paying for 6 providers millions of dollars when people weren't fully paneled. So a lot of discussion and a lot of attention to how do we open panels, how do we redistribute panels, which practices are performing and underperforming and aren't meeting financial targets. And we did risk stratification with those practices that we'll talk about in a few minutes. There was a great shift in how they paneled when they considered adjusted panels. So those providers who had very high risk panels should have lower numbers of patients than those that didn't. Also help them really be more sophisticated and intentional with how they assign their population health management resources. So instead of thinking every practice gets a certain amount of care management or every practice gets a certain amount of behavioral health, it really helps them zero in and narrow down on the practices and those provider panels that had the highest risk patients in them. So powerful data. Still to this day, I'm in touch with that group 4 years later, and they said that's the single most used tool by their providers in an ongoing way. Their providers are constantly in that empowerment and risk stratification tool, updating their panels and updating their risk status to adjust their panels. A lot of this, empanelment is so foundational. It's the first step for transformation. It gives you instant ability to provide better access and continuity. As I already mentioned, it allows you to risk stratify which of your patients need basic care coordination, those that need care management, helps you sophisticate around population management, and ultimately helps you with purpose improvement. Isn't really see, so I'm going to switch over to our what's called our Empanelment Reference Guide Health Teamwork, and then we will be sending this out to you right after the webinar and using this for your homework assignment. So it defines empanelment, as you'll see here, and we've already done that together, so we're not going to do that now. We've talked about the why of empanelment. We're not going to do now. So we'll go down here to the steps to empanel. So on over these, I'm going to go over them once again, because again, I'm going to be asking you to go back and do this with your practice. So step one, again, is really deciding where the assigned PCP will be documented in your electronic health record. And the staff that only a panel manager, person, or team can update that field. We'll talk about step 4 below, but basically we don't want everybody going into the EHR and updating that field. 2, we're going to really create a definition of active patients. So you may already have a policy and procedure around active patients. It's worth a look again. It's determined by your system, like a hospital, if you're an owned practice. You have a standard definition, or you want to re-look at the one you have, you can use the MGMA active patient with 1 visit in the last 24 months, not including nurse visits. Definition that you can consider using. You can also create or customize a standard definition that makes sense for your practice. Initiating a cleanup of your panel. So using the 4-cut methodology, seeing the reference guide, or using another cleanup process that makes sense for your practice or system. Or I'm hearing they're static, and I'm not exactly sure what to do about it. I'm trying to get closer to the computer, but I apologize if we're having some static issues. So as I mentioned earlier, step 4 is really involve the patient and the provider in the panels. So behind the scenes, once you've gotten input from your providers that yes, you can follow the 4-cut method, and yes, they agree to the active patient definition, then you do all the work of cleanup. And this time is the time to run each provider's panel and practice panels for those of you at the system level and take that to them for their review. So it'll be a process between the panel manager and the providers to talk about which patients are actually part of their panel and which ones aren't. And a real stretch goal after the providers that we'll talk about in a minute is engaging the patients in a meaningful way to help make sure and confirm that for patients when they call for visits and when you're talking to them, that they confirm that the PCP that you have in the electronic health record matches the PCP that they consider their own. And 5, it says step 5 here, really it's a step 1, but to confirm here in step 5, who is your ongoing panel manager? So that panel manager is running a panel report each month, does review transfer of care requests. So if a patient requests a new provider or a provider says, this is not my patient anymore, that manager tracks patient status, including death, transfer, changes in the practice management system, monitors provider status changes. So if they leave or they go more part-time, they assign the patients. They notify any of the patients of any changes to their assigned PCP, and they panel management and balance in an ongoing way. And again, the process is look at your panel sizes and making sure you have appropriate panel sizes. And a stretch goal that isn't here, but I'll talk about in a minute, is considering risk-adjusted panels. So once you get really good at panel management and done a risk stratification process, how to adjust your panels to account for risk. So work assignment. So if you're new to this or you haven't done it for a long time, I want to start with steps 1 through 3. You'll have the reference guide, but steps 1 through 3 again are to define the area in your electronic health record that you all agree to document the PCP, or confirm your definition around an active patient, and it's really important to include your providers here and get their input, and identify a panel manager and initiate a cleanup of your panel. So your homework assignment between now and the call in 2 weeks, these 3 steps. Now, I'm not saying, I know for those of you at the system level, or you may be from a large practice, or it may take quite a bit of time to do this. When I say initiate a cleanup of your panel, I basically mean identify a panel manager, person or team, to use the format method or another method, and ideally create a plan that assigns who's going to do what by when to get your panel cleaned up. Whether you've done 1 through 3 and you've already cleaned up your panel, you'll get 3 gold stars. Now, if you're a practice or system that's already doing 1 through 3 and you feel like you have an ongoing active panel management process that works very well for you, you move on to steps 4 and 5. So number 4 would be define a process to engage patients in identifying his or her provider. So that's when people call for visits, you confirm who their provider is, or you do surveys and outreach to patients, or do that in your sort of ongoing orientation and physical exam process. But it's define a process to engage patients in this panel management process. If you do it intermittently and it needs to be better, step 5 would be, confirm or identify your panel manager, define ongoing panel management process, learning and practice transformation and performance management. Nothing happens if it's not well documented. So steps 5 can really be about defining your policies and procedures and assignments around panel management, aging patients, and finding how often and who does what, and that sort of thing for steps 4 and 5. If you're on 1 through 5 and you feel like that's all in place, we'll move on to step 6, which is thinking about how you might risk stratify your patients if you haven't already, and look at consider how you might start adjusting your panel sizes based on risk across provider panels or across your practices. This work assignment. So the beginning of the next community learning call, us polling you and you guys talking to each other about your barriers, how it went, how things are going, and sharing with each other this is going. So this homework assignment is really important, because if you do the homework assignment, then we're basically just having words and talking at you, and I know you won't get the most from hearing from each other. So would you please unmute the lines and also let us know if we've had chat questions along the way, and I'll be quiet for a minute. And then if you don't want to be unmuted, Heather will unmute you directly. If you don't want to be unmuted, please hit Control M as in Mary, because we will be able to hear everything you're saying. And if you want to talk as a team, hit Control M as in Mary, and that will mute you. I open it up for questions. Do we have chat questions that I can answer?
No, we don't have chat questions at this time. Everyone's unmuted.
Okay, before we move into an overview of risk stratification, does anyone have any questions or thoughts or good experiences with this or best practices that they want to share? Please feel free to speak them out or use the chat feature if you have any, if you don't want to talk out loud. Just 1 minute to see if they can think of any questions. If not, we'll move on to risk stratification and we can mute again. Okay, can we mute, and I'll move forward, and we'll have one more question time at the end here. Coming to our original our pyramid here, so we talked about empanelment, and I'm going to give a brief overview of risk stratification and definition on our next call. After you guys share about your empanelment process, we'll be into real methodology around risk stratification. We won't be doing a deep dive on that today, but let me give you an overview of risk stratification. So what is risk stratification? You may not know Asaf Baton. He's very involved in the Comprehensive Primary Care Initiative and SMI. Basically, this risk stratification as an intentional, planned, and proactive process carried out at the practice level to effectively target services to patients. It's to continue to move from a reactive single physician to a more proactive team of providers to address the total health needs of the total population of patients. Stratification essentially responds to the question, how to keep our sickest patients from getting sicker? And to that as well, how do we keep our moderately sick patients from getting sicker and our patients that are low risk from getting sicker? So really, we identify our patients with multiple sources of data, keep them moving up that pyramid to our high risk in their health. So ROC Plans is a partner here with Health Teamworks in Colorado, Comprehensive Primary Care Initiative. And they talk about risk stratification from the perspective of four necessary data points. Stratifying our patients into those at the lowest risk, moderately at risk, and highest risk. We should be using administrative data, like graphics, utilization and claims data, number of diagnoses, and things like that. We should use clinical data, so not only how many diagnoses might a patient have, but how severe is their illness, how many prescriptions are they on, so more levels of data besides just the sort of administrative data. Management. So there's provider input into the risk status. A provider might know that he has someone on his panel that has multiple diagnoses, they've been in the hospital multiple times, but they know that that person has an active and supportive spouse and that they're doing everything they can in the care plan to manage their care. So from the perspective of resource utilization, a provider might say, we don't need to assign extra resources to this patient. They might have community resource support or behavioral health provider. So this is where the clinical judgment comes in and says, I know this person on paper looks high risk, but really not. Or conversely, on paper, someone may not look high risk, but the provider may know that they're imminently homeless or they're facing something that it doesn't come out in the data. So the perfect judgment about entering the conversation about risk is crucial. And then patient-reported data, what kind of screenings are we doing with the patients? Are we doing the right ones? What kind of assessments are we doing? What are they saying in visits that would them low, moderately, or high risk? So look at all these data points together. And we'll be doing much more of a deep dive later in the next community call. What we're looking for here, so practices in Colorado that have been doing this for almost 5 years do it in a number of ways, and I'll talk to you about that more next time. But if you want to do it as simple as possible to be able to figure out how to allocate your resources. So from my perspective, there are 3 major chunks or levels of risk. The first in the green are our low-risk patients. So there are prevention patients. They have diagnosis codes to the knowledge of all those data points we talked about. They're not at imminent risk. And we're thinking about those low-risk patients as need a workflow for basic outreach. So I, Nicole Diener, need a mammogram, and I fall in the green patient level. I just need a letter or a call to remind me about my mammogram. So we want to be assigning high-level resources to people that basically need their prevention needs. But we want to do enough outreach to those who aren't following through with their prevention needs so that they don't move up in their risk category to that yellow, moderately risk section. So the yellow section, we consider those at moderate risk as they're at risk for a chronic condition, or they might have one or several chronic conditions that are managed. And so here we really want to look at a little more sophisticated care coordination activities. So it might not only be calling them in, having them come in, but it also might be following up with their goals, their referrals, making sure they're following through. So again, we don't need our highest cost, highest level resources necessarily for the yellow group. This is the group we can probably most impact right level of services for moving from the yellow to the red. And so look at which patients are activated, which ones will respond to services and they need. This yellow group is really ripe for intervention to prevent from moving into more of a lower quality of life and a higher cost. And so this yellow part is where we get more sophisticated in thinking about our population health management system. What do they need and who should provide it? Go to the red. This is looking at patients who might have comorbidities. They might have a chronic illness and a mental health or substance abuse having, ED and hospital admissions. They have multiple chronic illnesses. So I read a recent study that said that 25% of people that are originally in a high-risk category or very costly during a year will move out of that risk category in the next year. So these red ones, we heard that when someone's in a risk category, it doesn't mean they're there in a static way forever. So just like empanelment, we need to be thinking about in risk stratification, how do we keep this updated so that we're continually providing the right level of services to the right patients at the right time. In the red, we're really thinking about high level of care management services. So really, all along we should be managing transitions of care, but that's especially important here. So patient engagement and activation, transition of care management, outreach. So if we have services or we can partner with people who have services that provide behavioral health management at a higher license level, our more costly population health management services or partnerships should really be directed toward this red level of care. And I had helped teamworks over the last 10 years. We've really gone from our original thinking of diabetic registries and hypertension registries and depression registries to registries that are able to pull this type of data. And the reason is we were seeing a lot of our patients who had diabetes were also on our depression registry. So creating workflows where patients often crossed multiple conditions. So we're wasting resources and there were gaps and duplications. We're looking at patients through this lens. So last 4 or 5 years through the Comprehensive Primary Care Initiative, this health teamwork has more and more moved toward industry and population health management is really patients in these risk categories and really assigning any resources we can, any partnerships we can create based on this methodology. And the next webinar, we'll be going into different types of methodologies that practices are using for consideration. This can be a very simple process when you start. For example, asking every provider or the only provider in your practice, who do you think might die in the next year? Or who keeps you up at night? Or who are you most concerned about? And it can be it can literally be as simple as that when you first start, and those are your highest risk patients. But there are methodologies, and you come up with algorithms to make this a more administrative process with provider and patient review. So you can be more sophisticated and, again, in those population health management services you provide to patients. So you may be sitting there listening at the system level, and so you have different and more resources, and you may be doing it in one way, or doing it, everybody does it differently, and there's an opportunity to be more intentional about it. You listening in a tiny practice where you say, how in the world am I going to find resources to provide services at these different levels? And this is the conundrum we're in here between fee-for-service and value-based care. And it's not about how do we add 1 million resources to our practices, because as I've already mentioned, and if you know me at all, I'll tell you again, time, money, resources are not going to by themselves fix the problem. So it's about who is my how many risk patients do we have, what do they need? It's owning and managing your panel, your context, your resources to say, how do we continue to be more intentional, more and more empowered to understand our patient population, so as we move toward value, we're not there yet, we're preparing ourselves toward the population health management track. So maybe far along in this, you may not be able to move very far at all. But through the process of empanelment and risk stratification, you're starting to understand and own your data much more. So even if you can identify a resource you need desperately right now, it'd be an agreement with a community agency to co-locate or to have a good referral network. It may not mean being able to add a resource right now, but this will move you along the population health management track, or you become more sophisticated if you're already there to prepare for really intentional population health management. We probably won't open the lines again, so if you could use your chat feature for these few minutes that we have left, to pose a question, and Heather can read those out. I don't want to put you guys through the pain of silence and pressure to talk. So while we give you a couple minutes to potentially use the chat feature, I want to remind you again about some upcoming dates. But I'm going to put this up here again. So today we have our first community learning track call. March 10th, we'll be coming back together, and part of that we'll be polling you as attendees and hearing from you about your empanelment homework assignment. And it'll also be doing a deeper dive into risk stratification and your risk stratification homework assignment. And it'll be March 24th, again, hearing on risk stratification and then going into population health management, giving population health management assignment. And April 7th, we'll be hearing from you about your population health management assignment and talking about performance improvement. At 7th, Module 1 will close, and May will then be starting Module 2. And so you'll see below under the coming soon, Module 2 officially starts May 24th, and this pre-work webinar will be from 12 to 1. And put in your calendar the next in-person training date that I believe is in Dover, and Sarah can confirm is on June 7th. Do we have any questions in the chat feature?
We have, Nicole, is someone is asking if the slide deck, if they'll be receiving the slide deck.
So everyone, what will happen after this webinar is that Heather will send Sarah LaFave at University of Delaware the attendee list, and we'll receive the slide deck and the empanelment reference guide. This will also be posted where the other pre-work webinar was posted. And the recording of this webinar will eventually be posted, but in the meantime, you will receive the slide deck and the empanelment reference guide via email and attendee to this webinar. And wondering, we heard from Sarah that the last performance management in-person training that video will be posted soon as well, and you'll be hearing from Sarah. So these things will be recorded and be posted, and you will receive it in the meantime via email as an attendee.
And have any other questions?
Okay, seconds here to see if anybody comes question.
We meant from Bonnie Adler, who says that this seems like a good approach.
Please contact Sarah. Even you see her contact here, and I know she's been emailing you guys with updates and information. If you have any questions, if you want to get in touch with me or how Teamworks, if anything else between now and our next on March 10th, feel free to reach out and answer any detailed questions you have. In the meantime, I want to just say thank you for attending, and we really look forward to hearing back from you on March 10th about how your initial steps toward empanelment went or your review of processes. I think it'll really provide a lot of richness as you guys talk about how you're doing this together. So thank you for attending and participating, and we look forward to talking to you on March 10th.